Hello. So today we are going to discuss about chronic leukemias. So in the last podcast we have extensively discussed about the acute leukemias, and today we will just discuss about the chronic leukemia. And just for the sake of just a brief review, let's start again by discussing what leukemia is all about. So leukemia is basically the malignant proliferation of the white blood cells, and the cells appear in the blood. In contrast to lymphoma, in which we were said in the previous podcast that lymphoma is basically the malignancy of lymphocytes inside the lymph nodes. So in leukemia and lymphoma, the difference is the presence of the malignant cells in the blood versus in the lymph node. So leukemia is defined as malignant proliferation of the white blood cells when it appears in the blood. So again, we will quickly review the classification that leukemias are classified: myeloid versus lymphoid, acute versus chronic. In acute, we had said that it involves blasts in the bone marrow, which are the immature cells, and chronic leukemias usually have much more mature cells as compared to blasts. And the onset of the symptoms is also slower, not a rapid onset of symptoms just like in acute leukemia. So if we can see here again that myeloid disorders, basically the myeloid progenitor cells in the bone marrow can proliferate and can proliferate myeloblasts, which we will call acute myeloid leukemia, which we had discussed yesterday. But these myeloid progenitor cells can also help in production of the red blood cells, granulocytes, and platelets. And combined, all these disorders are known as myeloproliferative disorders because they are formed from the myeloid progenitor cells. So if increase in red blood cells is occurring, so we will say that disease as polycythemia vera. If increase in platelets is happening due to myeloid progenitor cell proliferation, so we will call that disease as essential thrombocytosis. And if granulocytes are increasing due to proliferation of the myeloid progenitor cells, we will say that it is a chronic myeloid leukemia. So what chronic myeloid leukemia is? The proliferation of myeloid progenitor cells that will eventually increase only the granulocytes. So when only granulocytes are increased in the bloodstream, we are saying that it is chronic myeloid leukemia, and it also comes under the umbrella of leukemias as well as myeloproliferative disorders, which we will discuss in the later podcasts. Now, chronic myeloid leukemia. It's basically a malignant disorder of myeloid progenitor cells in which there is the dysregulated production of granulocytes. Now, granulocytes, as we have discussed in the previous podcast, includes neutrophils, basophils, and eosinophils. So, this disorder has been classified under the umbrella of leukemias, as well as it has been classified as a disorder of myeloproliferative disorders. So when we see the peripheral blood in the chronic phase of the chronic myeloid leukemia, so what we will see, the first thing first is the leukocytosis. And usually the median white blood cell count in the peripheral blood is usually like 100,000 per microliter of white blood cells in the chronic myeloid leukemia. There will be the increase in number of the neutrophils as well as the precursor cells of the neutrophils. For example, as we know that when neutrophil is formed, so first of all the myeloblasts phase is there, then there is pro-myelocytes, then there are myelocytes, and then there are band cells, and then they eventually convert into the neutrophils. So all precursor cells of the neutrophils will be found in the chronic myelogenous leukemia, and then there are increase in basophils because basophils are also granulocytes. So it's the hallmark features of chronic myeloid leukemia, and very rare other diseases have increase in basophils. So when basophils are increased on a complete blood count report, so definitely suspicion of chronic myeloid leukemia has to be included in one of the differentials, and as well as there is also increase in eosinophils. So the chronic phase usually lasts for years as it is chronic. It makes sense, but this phase is usually asymptomatic. Only accidental finding of increased white blood cell on the blood testing. But you can have that symptoms of fatigue, malaise, weight loss, and upon palpation of spleen, you might notice splenomegaly. And there are also very few blasts, less than 2%, as expected, because in chronic leukemias or chronic myeloid leukemias, blasts are less as compared to the acute leukemias, where the blasts are greater than 20%. Then there is also accelerated phase as well, which usually occur within months, and it usually is described as a treatment failures phase, and in that phase there is sudden increase in the white blood cell count. Then the chronic myelogenous leukemia can also have that blast crisis in which CML can convert into the AML or ALL. So the blast crisis, basically what happens that CML can be converted into AML, acute myeloid leukemia, where there are greater than 20% of blasts in the periphery or bone marrow, and usually the AML is much more common, acute myeloid leukemia, as compared to ALL, which is less commonly found in blast crisis. So one of the things which you have to differentiate is the leukemia reaction versus chronic myeloid leukemia, because left shift or leukemia reaction is basically a normal response to infections. So what happened in an infection, that there is raised in neutrophils and bands. So this condition must be differentiated from CML, in which also there is increase in neutrophils and increase in bands. So normally the white blood cell count is like 10,000, but in infection it might raise towards 17,000. Neutrophils, differential neutrophils might be 55% in the normal. In infection it can lead towards 80%, and band cells normally 5% are found, and in infection you might notice that they are raised towards like 12%. So how we will differentiate a normal infection process as compared to the CML is the presence of LAP enzyme, which is also called leukocyte alkaline phosphatase. This enzyme is normally found in the normal neutrophils, but the point to be noted is that in CML, when neutrophils are increased, it will not contain this enzyme. So LAP enzyme is absent in the neutrophils of the CML, and this enzyme level assessed with LAP score, because for example in leukemia reaction you will find high LAP score because the neutrophils are containing that enzyme, but in CML this LAP score will be low because the neutrophils found in the CML will not contain this LAP enzyme. So this test has been largely replaced by the presence of the Philadelphia chromosome, but the point to be noted for our understanding is that LAP enzyme has to be in our mind, that yes, this LAP scoring is important to assess that whether the neutrophils which are present in the bloodstream are due to a normal infection process or due to some malignancy like chronic myeloid leukemia. So the Philadelphia chromosome is the genetic hallmark of the CML, in which 922 translocation can occur, and in this translocation what will happen that we will found BCR and ABL fusion gene. So when BCR and ABL will fuse together, what will it synthesize? It will synthesize tyrosinase kinase enzyme, tyrosinase kinase protein, and tyrosinase kinase protein, what will it will do, that it will evade apoptosis and cell will live forever. So long cell life, accumulation of these cells, and eventually the leukemia will occur. So Philadelphia chromosome genetic testing is important to assess that whether there is chronic myeloid leukemia or not, but still LAP score is also used, and as well as this Philadelphia chromosome is also used. So that's why the treatment of choice or the drug of choice for the chronic myeloid leukemia is tyrosinase kinase inhibitors like imatinib, etc. And it's used to control the disease, but it's not curative, and definitely for the permanent cure of this disease, bone marrow transplant is indicated when the treatment gets failed. Now, chronic lymphocytic leukemia. Now, chronic lymphocytic leukemia is basically a disorder of naive lymphocytes. Now, you have to differentiate between naive lymphocytes as compared to blasts. So, they are basically not blasts. They are much more mature cells than the blast, which are newly produced by the bone marrow cells. But the characteristic immunophenotype of CLL cells as the presence of B cells, but they will have co-expression of CD20 and CD5. So it's interesting to note that it is a B cell, but it is having the immunophenotyping of both T cells and B cells. So it will co-express CD20 and CD5. Now, you have to understand when you are reading about chronic lymphocytic leukemia, CLL, so there is also another disease which we have to know is small lymphocytic lymphoma, which is also called SLL. So it is having the same malignant cells as CLL, but it is differentiated from CLL by the degree of the lymphocytosis. So in CLL there is increase in white blood cell count, but in SLL there is usually mild lymphocytosis, usually less than 5,000, and in contrast CLL is having greater than 5,000 lymphocytes. So it's basically a spectrum of disease. SLL, when lymphocytes are less than 5,000, but when it becomes greater than 5,000, we will call it SLL. So the median age of presentation of CLL is 60 years of age, and patients are usually asymptomatic, and on routine CBC investigation you will see increase in lymphocytes. For example, only very minute patient like 5 to 10% of the patients have those classical B symptoms which are called fever, sweat, etc., but mostly they are asymptomatic. You can also find signs like lymphadenopathy, splenomegaly, hepatomegaly, but it's usually less common, and many patients are under strict observation without any treatment. So other thing which is important regarding CLL is the presence of the smudge cells, but this is the point to be noted that basically it's a malignancy of B cells, so B cells become a little bit fragile, the lymphocytes become fragile. So during slide preparation or during preparation of the blood smear, they are usually disrupted and seen on microscope as smudge cells. So the smudge cells are not found in the blood. Always remember that smudge cells are not found in the blood. This is usually a laboratory during the lab investigation when we are preparing the blood smear, so that smudge cells will be found, and they are usually due to the disruption of the peripheral lymphocytes due to its fragility while preparing blood smear. So B cell will, when it will be fragile, it will be disrupted, and disruption can occur, and when it is disrupted, so what we will expect is like the B cells are antibody secreting cells, so decrease in antibodies can occur, which is called hypogammaglobulinemia. So usually decrease in IgG, IgA, IgM can happen in CLL, and this condition lead towards increase in susceptibility of bacterial infections. The other thing worth mentioning about the CLL is the presence of the autoantibodies, which are not produced by the malignant cells but usually are produced by the non-neoplastic cells due to the process of self-reactivity, and hence it can lead towards autoimmune hemolytic anemia, which we will discuss in the latest podcast, that how autoimmune hemolytic anemia, CLL, can produce autoimmune hemolytic anemia. So CLL can transform into diffuse large B-cell lymphoma, and it's a feared complication of the CLL. So the classic presentation will be that the patient was having the non-CLL, and suddenly there is a rapid growth of a single lymph node, and when you will biopsy that lymph node, so you will find out diffuse large B-cell lymphoma. So another disorder which is worth mentioning is the hairy cell leukemia. It's also a rare chronic B-cell malignancy. Rare chronic B-cell malignancy, and it expresses CD19, 20 and 22, which are the markers of the B-cell, but the sensitive marker which is found in the hairy cell leukemia is the presence of CD103, and it's a sensitive marker of hairy cell leukemia. So on peripheral smear, what we will observe is the presence of the hairy cells, lymphocytes, in having hair-like cytoplasmic projections are found. So what does hairy cell leukemia have? Having a unique feature is the presence of the massive splenomegaly, like other leukemias as well. The red bulb of the spleen will become engorged with these cells, and it will obliterate the white bulb, and hence it will just produce the enlargement of the spleen. Hairy cell can also induce myelofibrosis, and hence there will be